Thanks once again, Jasmine and Penny, for that quick run through of Amazing Seniors news site. Ladies and gentlemen, if you're ready, I would like to now introduce our honored guest speaker, Dr. Akila Othman from Sunway Medical Center. And she is going to be presenting on the big C, or cancer. Now, I know this is a dreaded word, but what Dr. Akila will do is take you through debunking some cancer myths and talking about how we can manage cancer, when best to detect and treat cancer, and I think the most important thing of all, how can you prevent cancer? So Dr. Akila, if you're ready, the floor is yours.
Hi, I'm Dr. Osman, clinical oncologist in Sunway Medical Center in Malaysia. Many thanks for having me today. What we'll do to kickstart the program today is go through a very brief introduction of what cancer is and hopefully demystify the word a bit. So let me start off by sharing my screen. Here we go. So at any point in our lifetime, we will have normal cells and abnormal cells coexisting. It is when the ability to repair any abnormalities or expel these cells from our body that cancer has the ability to start developing and growing. It is when the growth of these cells become unchecked and they then have the ability to invade other tissues and they can then spread through the blood and lymph systems. This is when cancer develops. Technically, cancer can grow in any cell throughout the body, top to bottom, top to toe. There are more than 100 types of cancer, although what we commonly hear in the media or in the literature are the more common cancers. So as you can see from the Malaysian National Cancer Registry report dating back to 2012 to 2016, that the most common three cancers are the breast, colorectal, and lung cancers, which would be similar to the Western population. However, the difference is that you can see that the nasopharynx cancer makes it to the top 5 in terms of statistics in Malaysia, but obviously you will not see the same numbers in the Western population where these cancers are more rare. This is basically a pictorial on the demographics of cancer. The third statement basically states that 1 in 4 Malaysians will develop cancer by the time they reach the age of 75. Now, this is not surprising at all, given that we mentioned how cancer develops. By the time people age or as people grow older, their ability or their physiological mechanism to repair any sort of insults or injuries to their body or abnormalities will diminish. Therefore, the chances of any abnormal growth to prevail or not being expelled by the body is obviously higher. So age in itself is a risk factor for developing cancer. So to be honest, it's not at all surprising that this is the figure quoted of the number of people will develop cancer by the time they age, and obviously coupled with all the lifestyle factors and all the multimodality causes and reasons for developing cancer. This is pretty much accurate, I would say. And certainly I think the scary thought is if any of us are going to live long enough, then the chances are we will develop some sort of cancer at any point in time. Now, this pictorial by Cancer Research UK suggests that 4 in 10 cancers technically could be prevented. The first big one is basically cigarette smoking. Now, most of us know that cigarette smoking is bad for us. But how many people actually walk away when they are in the vicinity of other people who smoke, although they themselves are not smokers? So passive smoking is just as bad, at least just as bad. It technically may be worse if you are genetically predisposed to having some sort of cancer. You take extra precautions and don't smoke, but you are always in the vicinity of someone who smokes, then obviously your risk has been increased. And then the second one there, you could see maintaining a healthy weight, being safe in the sun, which is not too much of a problem here in Malaysia, although we have sun all year round. But clearly in the Western population, the risk of skin cancers, etc., is higher due to lower melanin in the skin and also other factors. But you could see that after that, avoiding certain substances at work, such as asbestos, now things like that sometimes is a bit difficult because obviously we are speaking about your livelihood. So obviously, if you have a choice, then that's good. But if you don't, you take certain precautions like having PPEs, personal protective equipment, etc. Now, this protection against certain infections and things such as HPV there, which is human papilloma virus, yes, that definitely is a major cause of cervical cancers, and definitely cervical cancers now technically can be prevented by having the HPV vaccinations. H. pylori, we don't have any vaccinations against that yet, and certainly for Epstein-Barr virus, which causes nasopharyngeal cancer in Malaysia or Southeast Asian population or even Asian populations, we don't have that yet. But certainly vaccinations for HPV virus is very, very helpful in terms of reducing the number of cervical cancer cases and also preventing such cases in the future. Drinking less alcohol, eating a high fiber diet, and all these are basically lifestyle measures that again we all know, but not many of us are very serious in terms of doing that. Avoiding unnecessary radiation, which is quite normal, and all of this in terms of lifestyle measures by cutting down on processed meat, refined sugar, and all of this is basically pretty much, again, I would hope that most of us would know anyways, but it's a matter of knowing what to do, what best to do, and applying it in a normal lifestyle and your normal daily life. This basically comes to the point where actually many cancers are not going to produce any symptoms. Many people actually, when they start developing cancer, when it's in very early stages, you probably wouldn't even know that you've got cancers because it's so early. And by the time you develop symptoms, it will be of a certain size. So certain lump, for example, would have to be by the range of 1.5 to 2 centimeters before you can actually feel it. Unless it's in a very obvious place, say for example your limb, where you can actually see something growing. But apart from that, say for example it's a lump in your breast, it takes very good clinical skills to pick it up, or you could actually feel it when it's only around about like a certain size. So the whole idea of screening is basically to pick up cancers when it is in very, very early stages, when the cancer has not even grown enough to basically be noticed by the individual. So when you pick up cancer early, you can basically have a very good outcome, and therefore hopefully the ability to cure cancer is going to be a lot higher. So this is where we come to this poster here talking about cancer screening, and it can definitely save lives. So we start off with one of the more common validated cancer screening tests, which is the breast cancer screening. So we suggest that by the age of 40, women in general should have the opportunity to speak to their doctors to say whether they are already at the age to start screening, and if they wish to really start at that point in time, they should be offered screening. Now, this poster here by the American Cancer Society has labeled for women with average risk. So most of us would be in average risk, but obviously if you've got a family history of cancer, and especially what we call a first degree family history of cancer, whereby you have a first degree family, i.e. your brother, sister, your siblings, who have cancer, especially diagnosed at an early age before the age of 40, or you've got a strong family history. In other words, for example, your maternal aunt, your maternal cousins, your siblings all have some sort of cancer, breast cancer, for example, then technically you are not in the average risk, then you are in a higher risk population. And therefore, you should be discussing screening earlier with your doctor before the age of 40, even in some cases, as you may be at risk of a genetic predisposition to cancer. Now, certainly, in most places, you will begin yearly mammograms by the age of 45. And again, when you speak about the correct test for breast cancer screening, mammograms are obviously easy. They are cheap, they're easily accessible, then it's easy. But if you're going to do screening at a younger age, then certainly the breast in general is going to be more dense. Then technically it may be that mammograms are not the best tool to actually have screening. So again, that's why it's important to discuss with your doctor whether an MRI would be better or ultrasound would be better. So things like this should be discussed with the doctors, but in general, the yearly mammogram should start by the age of 45 to pick up cancer. And again, this is a poster by the American Cancer Society speaking about colorectal cancer screening. By the age of 45 to 75, people should already start screening for bowel cancers, which is very, very common. And again, we do colorectal cancer screenings is because when it's very, very early in the lining of the bowel, there would not be any symptoms. By the time you actually see blood in the stool, by the time you feel any symptoms such as bloatedness or a mass in the abdomen where you can actually feel it, when you can palpate it as a doctor, then it is actually quite big to be causing those symptoms. So the screening for colorectal cancers are actually quite easy. There are non-invasive screenings like stool-based tests, whereby in the UK, when you reach a certain age, they actually send it out in the post. All you need to do is basically take out the kit and actually put a sample of stool in there, mail it back to the GP, and if it's positive for blood, so what we call occult blood, so in other words, you do not see the blood when you're actually visualizing your stool yourself, then obviously there will be more tests to be done and the individual will be called into their GP to basically get these investigations and other investigations arranged for them. The other method that is slightly more invasive is having a visual examination of the lining of the bowel itself. This is again by having a colonoscopy, and again, some people find that this is rather uncomfortable or they're rather embarrassed about doing it. But again, it just depends on the risk of the patient, the age of the patient, and obviously are they at an average risk or at that of a high risk. So they're on a high risk, then you would basically be proposing that actually a colonoscopy would probably be better if again they have a very strong family history, or they are already known to have a history of polyps, or they are already known to have certain medical conditions like ulcerative colitis, inflammatory bowel disease, and all of this which in itself predisposes to cancer conditions, then obviously colonoscopies are better. So again, which test to use to be discussed individually with your own individual physicians. Now, cervical cancer screening, and again, I previously mentioned about the HPV vaccination, but in women who unfortunately have not had the HPV vaccination are at risk of cervical cancer if they are sexually active, then they should start having cervical cancer screening, which in itself can reduce the risk of cervical cancer by 70%, as if any abnormalities, in other words, any changes before they turn into cancer, precancerous changes are picked up. They can then be easily removed and then prevent cancer from developing. And you could see down there that if it was picked up at a very early stage, the survival is more than 85%. So this is how screening is very, very important. But the uptake rate, unfortunately, is not that good in Malaysia as compared to the Western population. Here we have a very brief slide, I would say, a very, very simplified slide of the cancer treatment options that are available. And certainly if you speak about early cancers, then you will have the option of surgery in general, but there are obviously certain cancers like nasopharynx cancer, where it's a very difficult area to access by surgery. Then certainly you will be thinking about treating with chemotherapy and radiotherapy. And obviously these days, with the era of personalized medicine, etc., we have the option of targeted treatments, we have immunotherapy, we have hormone therapy, and obviously for our hematologists, we have bone marrow transplants, etc., for hematological conditions. But again, this is a very, very brief and not exhaustive um, list of the treatment options that are available. And I would like to stress that every cancer patients will need to discuss this with their oncologist on which treatment is the best for their cancer. Obviously, again, sometimes just not one treatment is going to do the job. You will need to have what we call a multimodality treatment to reduce the risk of cancer. Say, for example, you've got very early breast cancer, but the biology of it is actually quite bad. In other words, the risk of it relapsing is quite high, then surgery in itself is not going to do the job. So you will have surgery, and you will also have other modalities to basically reduce the risk of cancer in the future. It's just not about treatment at that point in time. It's also about treating to prevent the cancer from relapsing in the future, therefore extending the overall survival of a patient and increasing the chances of cure. So all of these are basically very individualized and need to be discussed with the individual on an individual basis clearly. This slide basically suggests the usage of what we call precision medicine. So obviously what happens these days, when you diagnose cancer in general, in the majority of cases, you will have either a big surgical specimen, or you have a small specimen in what we call a biopsy to confirm that it is a cancer and the type of cancer that it is. And then what happens is that it gets sent off for molecular tests. So this is quite helpful in terms of treatment. So what we do is that if we find what we call a targetable mutation, so in other words, there is some mutation, some alteration in the genes that has basically been detected to be the cause of the cancer, we then can have treatment options specifically for that cancer. Okay, so for example, say a person having breast cancer compared to another person who is also having breast cancer, one may have, for example, a HER2 positive breast cancer, and the other person also has breast cancer but actually have a HER2 negative breast cancer. So technically, with this information, they can have what we call targeted treatments with trastuzumab based treatment for the HER2 positive cancers, but the one who is HER2 negative will not benefit from this, as we have checked. But the thing is, the whole point about this is about checking. If we do not check, then we do not know whether this person has a targetable treatment option at all. So certainly the treatment paradigm, for example, in lung cancers, in the past, it is all chemotherapy. And obviously, you know very well in the past, if you say you've got metastatic or stage 4 lung cancers, the prognosis is quite dismal. The overall survival is not that good, and the response rate is not that durable, basically. But obviously, these days, we have discovered that quite a lot of people, especially in the non-smoking population, Asian women, many are harboring what we call a targetable mutation, for example, an EGFR or ALK mutation, or even a ROS1 mutation. And these are only found if we actually test for them. So if you only do a biopsy, it's just going to tell you that it is a cancer originating from the lung, but it doesn't tell you, the exact alterations there are. So if you do find, for example, a targetable mutation in some of these individuals, for example, an EGFR positive lung cancer, so you've got a mutation in the EGFR gene, then certainly there are options of oral targeted treatment. An EGFR inhibitor, they are oral, So these patients may not necessarily need to go down the route of chemotherapy, the IV chemotherapy, and they actually do better on the targetable treatment options in terms of quality of life, in terms of response rates, in terms of survival. So all of these are made possible by the development of molecular testing, next generation sequencing, genetics testing, and all of these are basically put into application by us practitioners when treating the patient. So we don't also just have treatment developments in systemic treatment, but the technology in terms of radiotherapy has also improved with time. So these are basically just some of the machines that is available in Malaysia. Okay. It's just not about the machines though, it's also about the techniques that we do in terms of reducing the potential side effects to the organs at risk. We've got our pharmaceutical companies working on all the drugs that I've mentioned previously, targeted treatments, immunotherapy, etc. But at the same time, on another aspect, the radiotherapy machines, the radiotherapy techniques, the applications basically have also improved with time and will continue to improve. And certainly, for example, you've got, the TrueBeam machines, the tomotherapy machines, and we treat by, IMRT techniques, VMAT techniques. This is all quite alien words, most probably to some, but actually what the main aim of modern therapy, radiotherapy do is basically just to reduce the potential side effects, or rather not provide unnecessary radiation to areas that we are not planning to target. So at any point in time, we can actually treat the area that we want to treat, either to cure it, so this is what we call in radical settings, or to treat it before we actually do definitive surgery so that we can shrink the tumor beforehand, or in cases where it's a bit more advanced, and what we are trying to do is to relieve symptoms. For example, in patients who have very big cancers and they're causing pain and pressure, then again, radiotherapy can do that. But to get to those areas, we will have to treat from the outside, going through the skin and through some organs, reaching the area where we are wanting to target. And all these areas will, in the past, have what we call collateral damage. And all this collateral damage basically can be reduced if we have a better technique. So certainly, this is where all this come into play, where these new machines are into play. But obviously, it all just depends on the clinical indications, how we actually apply all of this together. So one of these machines here you could see is the gamma knife machine. So this is the top right of the icon here. When we use gamma knife radiosurgery, for example, as the name suggests, it's radiosurgery. There's actually, first of all, no knife, as we are using gamma rays, so radiotherapy basically, to treat the patient in a so-called surgery. But again, this is not surgery. So the patient comes in, gets treated, for example, for brain mets, metastatic disease in the brain. There's no scalpel, there's no surgical wound. The patient has very minimal toxicities. There's very minimal areas that are going to be a result as collateral damage. So patients do very well with this technique of treatment. So there's many things that we can do. So as I said, it's not just about drugs, it's also about machine development, technique development, etc. And this machine here, for example, again, is a machine where we can do intraoperative radiotherapy. So for example, when a patient comes in for their surgery, for example, the breast surgery, during the surgery, the cavity of the breast tumor, we can actually just target this area here into what we call intraoperative radiotherapy. So it's all done in one setting during the surgery. So it saves the patient from coming in and out again for radiotherapy thereafter, to reduce the risk of relapse of the breast cancer. And certainly again, this is geared towards improving patient journey and making them more comfortable in their journey. So there's many things that have changed compared to 20, 30 years ago, not just drugs, but also radiotherapy, the modality, the ability to even reduce the risk of, say, for example, heart toxicities and things when we give radiotherapy. So all these examples are clearly not exhaustive, you know, what we do as clinicians are basically applying what our good colleagues are doing, you know, doing the research, the development of all things, trying to improve patient journey, trying to improve cancer care. So I myself as a clinician am very, very helpful and grateful to all my colleagues who are actually doing this. And I think we'll be having quite many talks today with regards to some research, some developments in cancer research. Okay, so that's it for me today. So I'll be happy to basically take some questions after this. Thank you very much.
Thank you, Dr. Akila. That was very, very educational. Yes, we do have a bunch of questions. If you're ready, I'll start with the first question. The first one is by Fong Lai Chen, who asks, what should we eat to, well, I think she used the word here, maintain, but I think it's the wrong word. What should we eat to prevent breast cancer?
I think as we've mentioned earlier in my talk, basically the prevention of breast cancer is obviously quite a number of factors. I think start off with, if you've passed a certain age, then chances of it being genetics that's driving the cancer is probably going to be less and less. And if you don't have any family history of breast cancer to start off with, then the chances of genetics is pretty low. So you think about lifestyle factors. So, and as I've mentioned previously, we all know this. So, you know, if you smoke, do not smoke, stop smoking. You exercise regularly and you have a healthy, well-balanced diet. I think that's the main thing that we can do for breast cancers, really. Also, if you are in the age of basically, the screening age, basically, so between the ages of 40 to 75, plus minus, then certainly go and get your mammograms done. So this is basically picking up cancers, or rather pre-cancerous changes before it turns into cancer. In other words, taking out lumps that may have the potential to turn into cancers earlier. So that's one of the measures to try and prevent breast cancer.
Great, thank you for that. Lam, we hope that answers your question. The next question is by Fanslan, who says, my late wife went for a mammogram after she felt a lump in her breast. Even though the result came in negative, she developed third stage breast cancer just 3 months later. What could have gone wrong?
Now, without knowing the actual specifics of the case, it's quite difficult to comment and give a proper answer. But I think, you know, it's just a bit of a conjecture, really. So when he says that it's negative, is it negative on biopsy or is it negative post-surgery? So it's a bit difficult with regards to that. And then in terms of imaging, so again, it depends on the age of the actual individual. So sometimes what you see, although the mammogram did pick up a lump, if you stick a needle in, so if you think about a biopsy, right, it's just a very tiny needle going into a very big mass, so a big lump basically. So you're only taking a small representative portion of the actual mass unless you take the whole lot out. So when you look at that, there is sometimes what you call negative biopsies, but actually they're falsely negative. So although you've had a biopsy done, it doesn't necessarily mean that it's actually negative. That may be the first thing. The second thing as well, you may find that if you've had surgery and it's completely negative, this is pretty odd. It's highly unlikely within 3 months, okay? If it's coming from the same breast cancer, unless it's very, very aggressive, then it's a completely different matter, okay? Also, when you have mammograms, that is actually an indicator to say how suspicious this is. So when you say suspicious, there's a score. So there's a score from 1 to 5. The higher it is, the higher the chances of it being cancerous. So there is a score to tell the clinician that actually this looks more suspicious rather than a very benign or a non-cancerous change. So again, there's quite a number of things that comes into play. And sometimes when you get mammograms done as well, you may couple it again with ultrasound, with biopsies and things like that. So if things are more suspicious and the clinician who's ordering it finds that, this is not right, they may repeat the biopsy again, or they may do other tests to actually see whether, the staging is right. So I think it's just a matter of, diagnosing it right to start off with.
Okay, thank you. The next question we have is from Joanne, and I suppose this possibly falls in the category of whether it's a myth or a fact. She asked, unmarried people who are celibate will not get reproductive parts cancer. Is that correct?
False. So if it's a myth, certainly, because if you think about it, reproductive part cancers are actually, so we talk about it, there's a lot of it, okay? So if you're talking in women in general, you've got your ovaries, you've got your endometrium, your cervix, and your vagina. Chances of you getting cervical or vaginal cancer is absolutely zero if you're completely celibate. But you still have other organs, which is part of the reproductive tract up the way. So it's the ovarians and the endometrial. So even though you're celibate, you can still get it. So there's no issue in terms of that. So the sexually transmitted diseases, the ones that's caused by the vaccines, the virus, sorry, the HPV virus, are the cervical and the vaginal cancers. So those ones, people won't get it if they're celibate and they've never been sexually active. But higher up, definitely the risk is still there, especially, if you're a bit more in terms of being overweight, etc.
Okay. The next question we have is from Amanda, and she asks, is there a comprehensive test for cancer in general? For example, via a blood test, or is it necessary to do the various tests individually, for example, for breast, colon, etc.?
So it would be great if you do have one test that's going to pick up something, but actually we don't. Simply because of the way that cancer works. And even when we talk about one cancer itself, so I'll give you an example. So breast cancer, for example, you can see on a scan that someone has breast cancer, but the biology of it or the tumor itself will have different characteristics from person to person because cancer is much more advanced than that. So without testing the actual tumor characteristic or the actual biology of the tumor, then we don't actually know. And when we speak about blood tests, and this might allude to basically cancer markers, which sometimes you hear in the media, or sometimes when you go for blood tests, then they talk about cancer markers. So not all cancers produce cancer markers, and some of the cancer markers that are being tested are not specific for specific cancers. So you might find that some cancers are, if you've got a cancer, for example, colon cancer, then you might find that your CEA is going to be raised, but you may also find colon cancers that do not have a raised CEA. So in terms of a blood test per se, it may be all negative, but without proper looking, proper scans or things like that, you may not actually see the cancer itself. And also cancer in its early stages is not going to come up with signs showing up in the bloodstream, etc. And even on scans, you need to know what you're looking for. So if you do not have any symptoms, then you go in randomly for a scan, it may be easily missed unless you have a very, very specific scan like a PET scan. And even then, if you're doing it, say, just out of the blue, you may easily, again, miss things. So this is why, as clinicians or doctors, when we see people, we recommend specific tests based on the symptoms that you're having. If you're not having any symptoms, you're certainly coming in for screening, in other words, trying to pick up things, then it's very, very different in terms of what is required and what is needed.
Okay, thank you for that, Doctor. The next question from Lim Kit Shin, who asks, if a colonoscopy can't be done due to a twisted colon, is a CT colonography an alternative scan? And basically, what is a CT colonography and can it remove polyps?
Yes, So if you cannot do a colonoscopy for whatever reason, then the next best step is a CT colon, right? But if you think about it, a CT colon is just an imaging test. So you're nowhere near with anything that can actually remove the polyp in itself. Whereas a colonoscopy, you are going in with a camera, basically. So it's a camera test for short, or in layman's term. And inside, when you see something, in the actual scope itself, they can actually pass an instrument in and remove the polyp at the same sitting at the same time. Whereas a CT colon is literally just a picture of your insides. So it's a CT scan, basically. So nobody is going to be there to actually, pick it up in real time to actually remove the polyp. So that's not doable. So if you're thinking about intervention at the same time, colonoscopy is the way to go. But if you cannot have colonoscopy for whatever reason, yes, the next best thing is the CT scan.
Okay. Lim, we hope that answers the question for you. Next is another one from Amanda, who asks, can DNA testing be done to identify potential genetic cancer cells?
Yep, certainly. So it's very, very commonly done, especially in somebody who basically have cancer diagnosed at a very young age, especially if it's less than 40 years old, or they find that they've got many family members who've got cancer. And certainly we look at the trend, basically the types of cancer, the age of them being diagnosed with cancer, and then we suggest what the potential best genetics test would be to identify specific genetic changes. Now, there are companies out there who basically are promoting or offering certain DNA tests or genetics tests pretty out of the blue. And again, it needs to be used with caution because you don't really know what that actually means in terms of the results. So in terms of interpreting the results, when we specifically tell patients, you may be at risk of these certain mutations in certain genes, then there's ways, etc., to go about it and to prevent the cancer from coming back. And you may, end up with certain strategies to try and prevent the cancer. Whereas if you do a large panel test, in other words, you don't really know what you're looking for, but you're randomly just going for a test, you may pick something up or you may not. Now, when you may not pick something up, in a way, it's probably a good thing. So they'll probably tell you that you do not have a genetic predisposition to cancer, but it doesn't necessarily mean that you're not going to develop cancer. Because if you think about it again, genetics play a very, very small part in cancer cases these days. So there's also lifestyle changes, etc. So it may give a false reassurance as well. So it's a bit difficult. So I would say tread with caution.
Okay. Thank you, Dr. Akila. Thank you for your patience as well. We still have a few more questions.
That's all right. That's all right. I've got time.
Okay, great. Thank you. This is from Joanne, who asks, Pap smears are scary. Is there any other way to detect cancer?
Well, if you're talking specifically about cervical cancers, right? So Pap smear can be quite intrusive. So these days, they have the HPV test where you can actually learn to do it on your own in the comfort of your own house, basically. So it's basically testing the actual HPV virus in itself. So if you find that there's the virus that is present, then you may need to follow it up depending on the results, etc. In terms of frequency on what needs to be done and how often to be done, etc. But if it's negative, then the next test will be many years down the line. And again, you can do it on your own in the comfort of your own house. So rather than not doing any test at all, you can actually do a self-test. So, that in itself is actually validated. So that can be done.
Great. The next question we have is age-related, and Grace is asking if do women still need to do a mammogram after the age of 75?
So in general, no. But assuming you do not have a very strong family risk, but again, by the time you are above the age of 75, the chances of any genetic related changes is going to be very, very low, because if you have something like that, it will have been, you assume it would have developed by then. So in general, when you talk about screening, so you pick women up of a certain age. So the cutoff is actually 75, and obviously everybody's different. So it doesn't necessarily mean that you won't have breast cancer at the age of more than 75, but it just means that the chances of you having breast cancer at more than the age of 75 is pretty low. But also you need to take into account of your previous medical history. So if you've had previous breast cancers or you've got previous ovarian cancers or something along those lines, then it may be that 75 is not the right cutoff for you. But in general, people of moderate or low risk of breast cancer, then 75 is absolutely fine, assuming you are quite good in terms of doing your own self-examination. You're quite reliable into picking up your own symptoms, etc. So screening is no longer required above the age of 75.
Okay. We're down to our last question at the moment. And this is from Tan, who asks, if one had cancer 20 years ago, what is the possibility of it coming back as we age, especially endometrial cancer?
So if you think about it, cancer, as I've mentioned, sometimes the risk in general actually increases with age. So although you've had cancer 20 years ago, it's been treated. When it's past 20 years, the oncologists definitely we dare say that it's been cured, right? Now, it also depends on what type of cancer it is and what the stage of that cancer at that point in time, because every cancer behaves very, very differently. So when we talk about endometrial cancer, assuming it's an early stage endometrial cancer, you've had surgery, you've had all the necessary treatment to prevent the cancer from coming back, the chances of the actual endometrial cancer relapsing is probably quite low, with more than 20 years down the line. If it's something like breast cancer, then the chances is still there, 20 years, right? But if you talk about other cancers, again, if you think about it, age. So for example, if you've been diagnosed with endometrial cancer at the age of 50, 20 years down the line, you'll be 70 by now, okay? So you may still be at risk of other cancers at the age of 70, not just the endometrial cancer in its own.
Okay. Another one quickly slipped in, Doctor, if you're able to answer as well. And
Sure.
this is Tian Bing Ong, who asked, would being a vegan help reduce chances of getting cancer?
Being sorry?
Being a vegan.
Oh, yes. Okay.
Vegan.
So there's a bit of a, I'm not really sure whether it's a myth or not, to be honest. I don't really know the right answer to this. Now, many people actually, when they are being diagnosed with cancer, especially in these parts of the world, it's not that prevalent abroad in the UK, for example. So many people here, you're being in Malaysia, you find that once they've been diagnosed with cancer, there's lots of relatives and friends go around telling them, you need to change your diet, which is true. So you need to be more healthy, you need to change your lifestyle. But then they go vegetarian, and vegan is obviously one step up. Yeah. So in a way, that may be actually trying to eat healthily, which is good. Okay, it's all good for us. So the thing is, if you think about it logically, there are many cancer patients who have been lifelong vegans and lifelong vegetarians as well. So it's a bit difficult to pinpoint whether the actual thing is actually by you being vegan completely, or preventing or reducing the risk of relapse is actually being more healthy in terms of your lifestyle choices or in terms of your eating habit. So in other words, when even if you're not a vegan, even if you're not a vegetarian, when you've had a diagnosis of cancer, you start cutting down on fried food, processed food, sugar and all of that. In general, your whole body is going to be a lot healthier. So I've got many patients who basically told me that, a year down after their cancer treatment, they feel a lot healthier compared to being diagnosed with cancer. It's simply because they have changed their lifestyle habits, they have changed their dietary intake, not necessarily being vegan or vegetarian. So it's more, eating healthily and more clean, basically. But as I said, I personally don't think that is the case, simply because I do see many lifelong vegetarians and vegans who do end up, unfortunately, with cancer as well.
And Dr. Akila, I promise this is the last question that we're going to take.
That's okay.
This one is from Chao Siu Huang, who asks, my 64-year-old sister had breast cancer and had a mastectomy last November. Even though she's had regular mammograms done, does this mean that the rest of us are at a higher risk, or is it otherwise, seeing that she got it at the age of 64?
So if you are 64, then the chances of cancer, as I've mentioned, age is pretty normal. Okay, well, relatively normal. We don't say normal, it's relatively normal. So unless it's what we call a triple negative cancer, so in other words, it's not driven by hormones, etc., then the chances of it being genetically driven is very, very low. And if she's the only first degree relative, or in other words, close relative that's had the diagnosis of cancer, then the chances of this individual or the rest of the family members having cancer is actually the same as everyone else. So I would say don't panic. It should be absolutely, as per normal. Unfortunately, it does happen with, increasing age. But you need to check the actual biology of the cancer itself. If it's triple negative, then the chances of it being driven by mutations or being genetics is probably higher compared to, a normal hormonal-driven breast cancer.
Great, great. Dr. Akila, thank you so very much. This has certainly, I think, been one of the most active sessions as far as questions are concerned. We thank everyone for their questions, and I would love it if everybody could join us as well in thanking Dr. Akila from Sunway Medical Center for taking the time today and for sharing so much about cancer and what we can do to prevent cancer and to look out for cancer. So thank you once again, Dr. Akila.
Thanks.
Now, ladies and gentlemen, this is the end of our current session at the moment.